That lecture never gets old for me. We're going to move on, and I'd like to introduce Dr. Kenneth Candido. Dr. Candido is an award-winning physician. He's board certified in pain management. Has led the pain management efforts at the Advocate Illinois Masonic Medical Center since 2007. He's a graduate and resident in New York Medical College. Dr. Candido completed his residency and pain management fellowship at the University of Illinois, Chicago. He'll be discussing the history of the opioid crisis in America. Thank you.
Good morning, everybody. Welcome back for day 2. Show of hands, how many people believe that the opioid epidemic had its origins here within the last 5 years in the United States? Show of hands. Last 10 years. Can I have my first slide, please?
Can't hear you.
Can't hear you.
Oh,
We're working on the AV stuff here.
how about this?
Yeah.
May I have the first slide, please?
He's got it. He's ready.
He took mine.
He's good.
What was your question?
My question was, who led the American League in hitting in 1901? Napoleon Lajoie, that's the right answer. Thank you for the guy in the back with the blue shirt. No, my question was, how many folks think that the opioid epidemic has had its origins within the last 5 years? Anybody? Last 10 years? Last 25 years?
Maybe.
What about last 150 years? So let me show you some history, and we'll try to stay back on time here. Dr. Swine, are we okay?
Almost.
We're almost okay.
Yeah.
Do not deduct this from my valuable time, please.
Will not. A break follows you, so you have it.
Ah,
Oh
great.
my God, don't kill my brakes.
Great. We have to support our exhibitors. So it's interesting if you look at the history of opioid consumption in the United States. Here we go. I have no disclosures related. Is this other little microphone on here?
Yeah, good.
Okay. Everyone can hear okay in the back?
Yeah.
I have no disclosures. I have an email address if you want to send hate mail to me at the conclusion of this. These are my learning objectives. I think you should be able to define the current, and I underline and italicize and emphasize the current opioid epidemic and put that into perspective with what we know about Americans. There's a reason why we have the ATF, right? Alcohol, tobacco, and firearms. Because Americans are addicted to all of those things. Think about it. Who comes up with the random moniker ATF, right? Such disparate concepts. Alcohol, tobacco. They could have substituted the word opioid for alcohol, tobacco, and firearms. That's what we're addicted to in this country, and we all know by current events that I'm not exaggerating at all. So let's talk about the current opioid epidemic. Let's talk about the role, or if there is one, for the pharmaceutical industry. Do they bear any responsibility for our present-day opioid epidemic, and what are the future directions? So let's go to the past. This was actually taken from a peer-reviewed article, and there's a glaring mistake in it. Opium was not synthesized in 1904, but actually Frederick Turner in Austria, who was a pharmacy assistant, 21 years old, tinkering in his laboratory, was able to isolate morphine from opium back in 1804. And that was a remarkable advancement in the annals of medical history. So, because before that we had opium, which was a reasonably good analgesic. It was reasonably good at stopping things like dysentery, diarrhea, helping infants sleep, right? Your baby was crying in the next room, you'd go over and rub a little laudanum on the baby's tongue and lips and go right off to sleep, and so forth. And then we had mass production of morphine. In 1853 in Scotland, we had the production of the hollow needle and syringe by Alexander Wood. So Frederick Turner and Alexander Wood are critically important figures in the modern opioid epidemic, but for disparate reasons. Before we had the availability of morphine, we had opium, of course. Laudanum was frequently used in the 18th century, 19th century as an aid to basically resolve any malady that affected the usual and customary individual. And then we had Frederick Turner, 21 years old. He wasn't even a full-fledged pharmacist. He was a pharmacy assistant. And he had a large basement. In the basement of the pharmacy, he was tinkering around. He was able to isolate morphine from opium. So this is a massive, incredible advancement in the annals of modern medical history. And coupling this with the isolation and creation of the modern hypodermic syringe and hollow needle by Alexander Wood in Scotland, we had the ability now for the first time in 1853 to administer morphine and other substances either intramuscularly or possibly intravenously. And it was always stated, but stated incorrectly, that Alexander Wood's wife was one of the first known casualties of the opioid epidemic, succumbing to an opioid addiction. In fact, that is a falsehood, and that's misinformation and false news. But Alexander Wood declares his space in modern medical history as an innovator. Now, what is 1853? Well, it's immediately preceding the American Civil War. And so in the American Civil War, which was by and large the number one war in the entire history of America with casualties, we had 620,000 deaths. That's almost the exact number of all the other wars combined in terms of casualties. But some don't reckon, so you can look at the actual casualties. Deadliest war in U.S. history by far. And if you add up all the other wars, World War II, World War I, Korean War, Vietnam, the Iraq and Afghanistan conflicts and so forth, that barely equals the number of individuals who died on both sides in the American Civil War. Many of you don't recognize, however, that we also had about 400,000 addicts. Now, how do we know that number? Well, we really don't know that number, right? We didn't have smartphones and cell phones. We didn't have access to mass media. It took about a week to produce the common newspaper, so information was scant. And so we have to go by sales and production of types of chemicals which were utilized, and primarily it was morphine. And the vast majority of individuals who became addicted to morphine didn't become addicted during the war, but actually after the war, and yet and still morphine consumption was known as soldier's disease. So we had our first opioid epidemic during the time of the American Civil War. Soldier's disease or Army's disease characterizes the almost 400,000 Americans on both sides who were acutely addicted and chronically addicted to the consumption of morphine. Interestingly, C.R. Alderwright in the United Kingdom recognized the addictive properties of morphine, and he actually had very good intentions. He said, I'm going to create a compound which is going to be useful for pain and useful for dysentery and useful for all the things that we use morphine for, but it's going to be less addictive. What did he come up with? Anybody know? He came up with heroin, diacetyl morphine. And so we all know, obviously, the misperceptions of Alderwright. He was a brilliant scientist, however, and he conceptualized creating a chemical compound which would be useful for pain management, but which would be less addictive than the actual addictive properties of morphine. Interestingly, the Bayer company didn't make their fortune, their billions, actually selling aspirin, right? We all know about Bayer aspirin, but they actually made their fortune selling heroin. For a 15-year period, up until 1913, Bayer made millions and millions upon millions of dollars, not selling aspirin, but actually selling heroin. And so how was that possible, and why did they stop the mass production of heroin by 1913? Well, that corresponds to the Harrison Act of 1914. We'll talk about that. Now, interestingly, we all know about switching addictions. We all know that addiction can be a chemical a concept of the brain. It can be a genetic predisposition to this. William Stewart Halsted, one of the greatest figures in modern American medicine, who helped create Johns Hopkins University, in fact is considered to be the father of modern surgery in the United States, was actually a notorious, raging cocaine addict. And so he went to Sigmund Freud. Actually, Freud was in Vienna. He actually never met Freud, but went to Vienna, where all Freud's disciples were utilizing and touting the great concept of using morphine to cure cocaine addiction. And in point of fact, Halsted became then a morphine addict by giving up cocaine in favor of morphine. The first pain clinic was started in the United States in the 1930s by the great John J. Bonica, who was from a small island right off of the coast of Sicily. I had the privilege of meeting Bonica and actually anesthetizing his wife, Emma, in New York City when an ophthalmologist named Dr. Stephen Opsbaum brought her from Seattle, Washington, where she had had a botched eye surgery and actually tried to repair that in the 1990s. And Bonica, of course, is the father of modern American pain management. So the first drug laws were created in the city of San Francisco. If you go back in time to 1875, you recognize the great city of San Francisco was noted for its opium dens, right? We had all the influx of Chinese immigrants to the United States, primarily to California, for the gold rush of 1849. You've heard of the San Francisco 49ers. And they also stayed to build the Transcontinental Railroad, which was completed in 1869. But after the gold rush was over and after the Continental Railroad had been completed, what happened? Well, the Chinese stayed. And they turned San Francisco into a large opium den. It was filled with squalor. there was drugs, there was prostitution, there was gambling, there was human waste littering the streets. In fact, it was just like San Francisco today. Nothing has changed in 140 years or so. And so the first laws were actually created to try to eradicate the Chinese from San Francisco. The well-intentioned populace of San Francisco wanted to liberate their city from the scourge of these Chinese immigrants. Then we had in the 1900s a new focus on cocaine among Southern African American individuals. And so the first drug laws in this country were actually created to try to focus on two minority groups. This is one of the opium dens, and what was happening in San Francisco in 1875, pretty much exactly the same as what we see today in 2019. The Pure Food and Drug Act was created in 1906 in an attempt to label patent medications which contained opiates and cocaine, alcohol and cannabis and other controlled substances which were at that time uncontrolled. In fact, in 1906, you could open up the Sears Roebuck catalog and you could actually order hypodermic syringes, you could order cocaine, and you could order opium directly from Sears, Roebuck and Company. And so it wasn't until 1914 that a Democratic congressman from New York State named Francis Burton Harrison created the Harrison Act. And the Harrison Act was a United States federal law which is created to regulate and tax the production, the importation, the sale and distribution of opiates and coca products. Here's the Sears Roebuck catalog from 1906, and you can see this is excerpted from that. And you can see that directly there for pennies on the dollar, you could buy hollow syringes, hollow needles, you could buy opium, you could buy cocaine, you could buy marijuana, and all other vices directly from Sears, Roebuck and Company. Francis Burton Harrison was a fascinating character, married and divorced 5 times. Actually, his first wife died in a motor vehicle accident. And he actually was the governor of the country of the Philippines. But while he was in New York, he created the Harrison Act, which was famous. He was also famous for having died on the exact same day that I was born, in the exact same place that I was born, although I didn't know him. So what is the modern opioid epidemic all about? Well, in the 1980s, there were 2 scientific papers which were carelessly written in the peer-reviewed literature. The first in the New England Journal of Medicine by Porter and Jick. Very important. It was actually a letter to the editor. The other was 1986 by Russell Portnoy and Kathleen Foley, which stated that the chronic use of opioid analgesics and non-malignant pain in 38 patients did not lead to addiction. And then we'll talk about Victoria Ventafrida. So Jane Porter and Herschel Jick, who actually wrote this letter in the New England Journal, wished that they could retract it. And what did they look at? Retrospectively, they looked at 40,000 hospitalized patients, about 11,000 of whom had received opioids during their hospitalization, and only found 4 legitimized cases of addiction. And so Porter and Jick stated that the development of addiction is rare in medical patients with no history of addiction. Now, why was this important? Well, the pharmaceutical industry took this as gospel. They took this and ran with this information and started reproducing this letter to the editor as evidence that we ought to be using opioids in patients without a history of addiction to manage all sorts of non-malignant pain conditions. One of the individuals really who was at the forefront of the opioid epidemic and who is now basically possibly responsible for the actual closure of the American Pain Society, because he's actually become a turncoat. But in the 1970s and 1980s, Russell Portnoy and Kathleen Foley were promoters of opioid use for chronic non-malignant pain. In fact, Portnoy received many, many hundreds of thousands of dollars from the pharmaceutical industry to go out and promote opioid use for chronic non-malignant pain. And in their 1986 paper, they stated that patients with intractable non-malignant pain and no history of drug abuse ought to be receiving opioids in escalating dosages. Now remember, this was based on a very small case series of 38 total patients. And so what happened here? Well, the pharmaceutical industry, people like Purdue Pharma, started to take these 2 small articles, this one retrospective review of 40,000 hospitalized patients of Porter and Jick, and these 38 cases of Foley and Portnoy, and started to say, see, there's medical evidence in favor of the use of opioids in chronic non-malignant pain, and nobody gets harmed. In fact, it came as no surprise that, and this is published in the Wall Street Journal, that Portnoy had disclosed relationships with more than a dozen companies, almost all of them that produced opioids, and for which he received millions of dollars in royalties in speakers' fees. Vittorio Ventafrida, I want to mention him in passing. He was not an individual responsible for the opioid epidemic, but he has a history which somewhat mirrors my own, both from his background, and he also completed his residency in anesthesiology at the University of Illinois College of Medicine, which is also where I trained. And he was actually one of the founders of the World Health Organization. He helped to create the World Health Organization stepladder approach to pain, and along with John Bonica was very important for the National Cancer Institute and for managing cancer pain. But if you look at the World Health Organization stepladder approach for managing pain, and we started out using this exclusively for cancer, but this can also be utilized for non-malignancy related pain, you realize that we shouldn't be using opioids at all for low levels of pain, for mild pain, 1 to 3 out of 10. Even for moderate levels of pain, 4 to 7 out of 10, we should only be using short-acting opioids and only in very short courses. So the vast majority of our patients, if they're honest, and if we show them the 11-point numeric rating scale about what really constitutes levels of pain, the vast majority of our patients need either no opiates whatsoever or only very short courses of immediate release opioids, but certainly not the high level opioids on an extended duration, which should be reserved for severe levels of pain. So what happened in the present? Well, in the present we have a new opioid epidemic, right? We've had an opioid epidemic in this country for more than 150 years, but in the 1980s, stimulated by those two poorly written and poorly crafted peer-reviewed articles which appeared, one as a letter to the editor and one as a small study of 38 patients, the pharmaceutical industry began to take this information and tell its representatives to go from office to office to promote the use of opioids for the management of chronic non-malignant pain. In response to this, 3 of the highest level representatives from Purdue Pharma were actually indicted. They were indicted for misdemeanor branding, which actually meant that they were instructing their reps to go from office to office, primary care offices especially, but also pain management offices, to promote the use of drugs like OxyContin and oxycodone for chronic non-malignant pain. And so the United States federal government levied a fine of $634 million to Purdue Pharma, and that wasn't chump change. That was about 1/4 of their gross revenue for that year in 2007 of $2.8 billion. But it was a significant attempt to try to stem the use of this promotion, this false promotion of opioids for chronic non-malignant pain. The Sackler family from Bristol, Connecticut actually is the family that owns Purdue Pharma. Many of you have heard of them. They created one of the wings at the Guggenheim Museum in New York City, and they're actually being run out of New York City. They used to run high in the social circles, and now they're being ostracized for their contribution to the present-day opioid epidemic. This is their headquarters in Connecticut. So the Joint Commission, we've all heard of the Joint Commission, right? They're also complicit in the opioid epidemic. Well, how do they become complicit? And of course they deny this, they run for cover, but they created a primer for primary care physicians in the 1980s, which stated that there was an attitude which prevailed despite the fact that there is no evidence that addiction is a significant issue when persons are given opioids for pain control. Who funded the primer that the Joint Commission published and disseminated and distributed to all primary care offices in the country? Purdue Pharma. So Purdue Pharma was the entity that gave the money for the Joint Commission to create and disseminate this primer. Of course they deny that, but it's all true, and that primer still exists. In 2015, about 1 out of 25 Americans got a prescription for a long-acting opioid. In 2017, we know that the United States constitutes about 4.4% of the world's population of 7.2 billion people. So there are 325 million Americans. Do the math, that's about 4.4% of the entire world's population. So we consume 70 to 75% of all the prescription opioids in the world. How does that happen? Well, we have the ATF, right? Alcohol, tobacco, and firearms. Americans are addicted to many of these concepts, to the use of alcohol, to the use of tobacco, to the use of opioids, and to the use of firearms. It's endemic. It's something which is instilled upon us and which we've had historically and uniquely due to our Americanism going back to the American Civil War. So these are fascinating statistics taken from the journal Pain Physician. And if you look at the hydrocodone, for the last 15 years, almost 100% of all the hydrocodone prescriptions in the world are written for Americans, by Americans and for Americans, whereas about anywhere from 70 to 95% of all the oxycodones written for Americans In aggregate, anywhere from about 68% to 75% of all the opioid prescriptions in this world are written for Americans. We constitute 4.4% of the world's population of 7.2 billion people, but we consume about 3/4 of all the prescription narcotics. So recently, physicians have gotten the message. Interestingly, if you look at the CDC statistics, actually prescription writing by American physicians is actually on the decline. So why do we continue to have an escalating opioid epidemic? Largely due to the influx through our borders, and people will criticize our president for stating that we need tighter border control, but actually he's right in one respect. The vast majority of these illicit substances, including fentanyl and its derivatives, are streaming across our borders from Canada and from Mexico. Here's a Customs and Border Patrol officers posing next to 650 pounds of fentanyl and methamphetamine in January 2019. James McDonald, who's the Assistant Secretary for categorizing weapons of mass destruction, in February of 2019, actually February 22nd, classified fentanyl as a weapon of mass destruction. Now, is fentanyl a weapon of mass destruction? Where have we seen that in history? Well, in 2002, those of you who are old enough to remember will remember this hostage crisis which happened near Moscow in a theater. 40 armed rebels, Chechen rebels, actually seized a theater with 900 patrons in it outside of Moscow and held them hostage, demanding that the Russian government release certain prisoners that they had held captive for several years. And in response to that, the Russian Spetsnaz, anyone know what the Spetsnaz is? It's kind of a hybrid, like our FBI, a very secret organization, but very highly skilled killers that actually work at the behest of the government. They didn't really know how to liberate these hostages from this siege, and so they contacted the United States FBI. The FBI didn't know what to do, so they went to Theodore Stanley, who was a professor of pharmacology and anesthesiology at the University of Utah School of Medicine, and that's Dr. Ted Stanley, a very good friend of mine. He was known as Dr. Fentanyl. He died about 2 years ago. He actually created the fentanyl lollipop. You've heard of that. And he also worked with Janssen, Paul Janssen, and Janssen Pharmaceutical to create remifentanil, carfentanil, lofentanil. Now, some of these fentanyl derivatives are used for big game hunting, right? You take a couple of drops of carfentanil and put it on a dart, and you shoot it at a charging rhinoceros, and you stop him dead in his tracks. The rhinoceros is not dead. He continues to breathe, but he's totally anesthetized. And so the Spetsnaz went to our FBI, FBI went to Stanley, and Stanley said, well, you take a couple of drops of this drug called fentanyl, you put it in the ventilation system, and you're going to put everybody to sleep. Well, the Spetsnaz, of course, being hard-headed Russians, took that advice and actually put into 100 or 1,000 times fold what Stanley had recommended, and they ended up killing many of the patrons who didn't have gas masks on. Many of the rebels were killed as well when Spetsnaz finally got access to the theater and actually shot them or captured them. So, in addition to opioids in this country, we also have an epidemic of escalating use of methamphetamines. Why? Because Americans don't want to just take their narcotics and go to sleep. They want to be wide awake to feel the full effects of the narcotics. We have about 70,000 Americans dying each year in this country due to all drug overdoses, all categories. That's a big number, right? If you filled up Soldier Field where the Chicago Bears play football, that's about 68, almost 70,000 people. And if you did that every year and slaughtered everybody in the stadium, that's how many people die from drug overdoses in this country. But if you look at what's really killing people, it's other synthetic narcotics. So we really have leveled off in terms of prescription writing, killing patients, but now we see that the use of illegal, illicit substances streaming across our border from Canada and Mexico, primarily fentanyl. Those are the chemicals which are primarily killing individuals in massive numbers and massive quantities. So if you look at any opioid, we've got about 47,600 deaths per year in this country. You can see the representation of males being greater than females. But if you look at prescription opioid numbers, they've actually leveled off. And so the number of deaths due to physicians like those of us in this room who are generally well-intentioned, it's actually leveled off and actually on the decline. What's going up is the number of deaths due to prescription opioids with synthetic narcotics, primarily illicit fentanyl. How about overdose deaths involving heroin? Well, that's on the incline, but primarily heroin with other synthetic narcotics. Heroin deaths alone are actually somewhat on the decline. How about cocaine? Well, cocaine deaths alone are actually very, very level, but the incidence of deaths is on the increase or on the incline when they are mixed with other synthetic narcotics. Cocaine alone, not on the incline, basically stable, but cocaine deaths with other synthetic narcotics. And you see the pattern here. How about benzodiazepines? Once again, benzodiazepine deaths associated relatively flat, completely stable for the last 20 years or so, but benzodiazepine deaths in accordance and in conjunction with other synthetic narcotics continues to rise. And so we see a glaring mistake here because we've all been inundated and told that physicians are killing patients in record numbers. We are responsible for this mass murder of Americans. At Center for Disease Control actually did something which I've never seen. In early 2018, they admitted that they may have made a mistake. Well, how did they make a mistake? Because they lumped together, they grouped together all opioid deaths as being related to physician prescription writing, when in point of fact, the incline in deaths, the escalation in deaths is actually due not to prescription writing alone, but actually to prescription writing in conjunction with other synthetic narcotics. And that's a very important admission on behalf of the Center for Disease Control. So how did we get there? How did we go from the avoidance of opioid writing to indiscriminate opioid writing and back again? Well, I've already told you that the opioid epidemic from the 1980s was fueled by the pharmaceutical industry indiscriminately taking these two papers, one in the New England Journal of Medicine and one in the Journal of Pain, and utilizing that as evidence for why we ought to be prescribing greater degrees of opioids for our patients. I also showed you this graphic that almost every molecule of hydrocodone prescribed to patients in the world is prescribed to Americans, and about 75% of oxycodone, for an aggregate anywhere from 68.5% up to about 75% of all prescription narcotics being consumed by Americans. ATF, alcohol, tobacco, and firearms. That's who Americans are. That's our entitlement. That's our right, our birthright as Americans. And we are not going to change it unless we start in infancy. We go into our schools in kindergarten and start to change the culture of Americanism. So what is it about the lay press? Are they culpable? Are they implicit? Are they complicit in the opioid epidemic? Absolutely. You look at these recognizable non-peer-reviewed journals, Time Magazine, Business Week, U.S. News. They talk about the right way and the wrong way to treat pain. God help you if your doctor doesn't know the right way to treat pain. And back in those days, it was by the use of opioids. We talk about pain in militaristic terms. We talk about conquering pain, beating pain. We've declared a war on pain, just as we declared a war on hunger, poverty, illiteracy. We've lost all those wars, by the way. And now we want to also understand pain. America's become the United States of America's marijuana. We don't think that marijuana is a gateway. We had a great segment yesterday where individuals even stated marijuana is not a drug. I don't know, maybe it's not. It's a plant. I get it. It's not a medicinal. Well, what is it? And so is it a gateway? Is it not a gateway? I'm not an addictionologist. I don't know. But we certainly love our marijuana the same way we love our opioids. And then we talk about addiction in our lay press. And Americans don't really want to do any work to get unaddicted. They want to continue to use their opioids in ever-escalating doses and amounts. They want a vaccine. Americans want a vaccine for opioid addiction so they can use indiscriminately in any quantity at all and never suffer the consequences of addiction. So we want to continue the rampant use of opioids, but we want somebody to inject us or give us a pill, something out of a bottle, so we can do so, and we can do so indiscriminately. And of course, we sensationalize, and this is part of being American as well, we sensationalize all the creatures in our world and our domain, in Hollywood and elsewhere who've had addictive issues. We sensationalize them. Look at Michael Jackson. We called him the king of pain. Look at the chemicals he was consuming at the time of his death. Vicodin, Dilaudid, Xanax, Zoloft, Demerol, and of course Propofol, Visceral, Paxil, Prilosec. These are all the chemicals that he was consuming. We make a hero out of these figures, these tragic figures who overconsume and overindulge. Whitney Houston, we made her a hero. We sensationalized her death. Prince, we made him a hero. We sensationalized his death, even including pictures of him, the last picture known of him going to Walgreens to pick up 325 oxycodone tablets 2 days before his death. Immediately after succumbing on a private airplane coming back from a venue where he had to be rushed to a hospital and resuscitated for opioid overdose. And this is the last known photograph of Prince. So we sensationalize all these individuals. We glorify the use of drugs in America. It's as much of Americanism as alcohol, tobacco, and firearms. How about the physician casualties? Well, here's Tesher Martin. He's 83 years old. He wrote 2.2 million tablets of oxycodone, Percocet, and hydrocodone in a 10-year period, including killing several patients. And for a 26-year-old Staten Island man, he received 20 years in prison. He's a product of the opioid epidemic. Started out his career well-intentioned and ended up being a drug dealer and drug pusher. How about this individual right over here? Dr. Angela Williams. You can see from the graphic, this was just taken July 24th, 2019. Another casualty of the opioid epidemic. Got addicted, started using her own prescription pad to write prescriptions for herself, put on a disguise, showed up in pharmacies and got arrested writing for hydrocodone, oxycodone, going to jail for probably 20 years. But some of the greatest casualties that we don't talk about are such as this individual right here, Todd Graham. Now, Todd Graham did all the right things. He's an Indianapolis physician in his 50s who was told, be very careful when you prescribe opioids to your patients. So about a year and a half ago, Dr. Todd Graham was in his office, and a woman showed up with her husband, and she had been a patient at a primary care office, and the primary care physician, responding to the CDC mandate not to write opioids for extended duration, said, you better go to a pain doctor. So the patient shows up with her chronic, non-malignant, benign, orthopedic type of pain process due to a degenerative condition, and she says, I'm here for my oxycodone, and Dr. Graham says, well, I don't know you. And she goes, yeah, but I've been getting it from my primary care doctor. Now you have to write my oxycodone. And Dr. Graham says, no, I don't want to give you oxycodone for your chronic, non-malignant, benign pain condition. You don't need it. And the patient said, of course I need it. I've been taking my oxycodone for 15 years. I have to have my oxycodone. And Dr. Graham says, well, yeah, I've just met you. This is the first day I'll do a physical exam, and you come back. And the husband became irate and said, wait a minute, my wife's going to have a withdrawal. And Dr. Graham said, you know, that's not my problem. So at lunchtime, Dr. Graham went out to his car, drive to lunch, and the husband was waiting for Dr. Graham in the parking lot. And he approached Dr. Graham and pulled out a firearm and shot him twice in the head, and Dr. Graham died. Now, what did Dr. Graham do wrong? What did Dr. Graham do wrong? He did what any of us in this room ought to have done. He was careful, he was concerned, he was caring, and he was very conscientious. And for those 4 C's, he received 2 bullets in the back of his head. So what's the future? How do we manage the present day and the future opioid epidemic? We have a duty to identify high-risk patients, and I'm going to show you that in just a moment. We've got to do our physical exam. We've got to stratify patients. We've got to create treatment goals. We've got to avoid long-acting opioids at the initiation of treatment, and we've got to educate our patients regarding adverse events. This is actually from the ACIP guidelines for the responsible, safe, and effective prescription of opioids in chronic non-cancer pain. You have a duty, if you're sitting in this room, to pull up this article. Dr. Manchikanti has graciously made this available to you gratis on the website. You must read this. So what are the levels of evidence? Well, level 1 evidence is comprehensive assessment and documentation. Evidence 1, establish appropriate physical diagnoses and psychological diagnoses. Stratify patients based on risk. Establish treatment goals of opioid therapy with regard to pain relief and improvement in function. Now remember, your patients who are addicted don't show up to your pain management centers with the scarlet letter of A emblazoned upon their chest. So who are the high-risk patients? You've got to identify risks for aberrant behavior. There are biological risks. There are psychiatric risks. There are social risks. You must avail yourself of these risk factors. A male patient beneath the age of 45 who is a cigarette smoker, who's got a personal or family history of addiction or alcohol abuse, multiple motor vehicle accidents, psychiatric comorbidities. These are very high-risk patients. And then you've got to stratify patients. Are your patients coming to you at low risk? Are your patients coming to you at moderate risk? Or are your patients coming to you at high risk? And you've got to make a determination as to whether or not those patients meet sufficient criteria for the use of opioids or not. Finally, avoid long-acting opioids for the initiation of therapy. Do not use methadone except in very, very rare circumstances. Understand and educate patients regarding the effectiveness and adverse consequences of opioid use. Understand that there are similar efficacies for both short-acting and longer-acting opioids, and choose shorter-acting opioids except under unusual circumstances. And use long-acting opioids only in specific circumstances where there's severe intractable pain. That's level 1 evidence. Finally, monitor the patient for side effects, including nuisance side effects such as constipation, and manage them appropriately, including discontinuation of opioids when indicated. So we know that deaths are increasing, but deaths are not increasing because physicians are overprescribing opioids in present day medical circumstances. It's due to the influx of these chemicals, including fentanyl, coming across our borders. And heroin deaths are increasing, but heroin with other synthetic narcotics is on the escalating dose, escalation higher than any other factor responsible for deaths in this country. Now, we know that these two individuals, the Prime Minister of Canada and our President, don't really get along very much, but I have to admit that the Canadians do a great deal of work in terms of stemming the opioid epidemic. In fact, they lead the entire world, including beating us, international use of 6 powerful opioids. So the Canadians have their own fish to fry, they've got their own issues to contend with, and they are also have an epidemic which has not escaped the lay press to the extent that the American epidemic has, and they've got a lot of work to do as well. So in conclusions, through 2019, drug overdose does remain a large and growing public health crisis. Prescription opioids were formerly driving the modern day opioid epidemic, but now we have illicit substances streaming across our border, fentanyl, cocaine, and heroin, and methamphetamines that we really have to contend with. And those of you who hate the president, like the president, love the president, have to admit that we do have to have border control in terms of stemming the influx of these illegal chemicals. We have a leveling off, and we actually have a decline in opioid prescribing since the year 2012 in this country, but we need more urgent measures to address the diverse and growing list of drug classes and types. And I thank you for your time.